Hello again. It's our pleasure to welcome Dr. Linda Bergum to Tuesday Group. On behalf of the American Association of University Women Ely branch and the Awareness and Change series. Dr. Bergum will speak today about treaty promises and Indigenous healthcare. She received her doctorate from the University of Minnesota Medical School and graduated from the residency program at North Memorial Hospital. After 5 years as a clinical physician, she joined the University of Minnesota faculty as an assistant professor in family medicine and community health. Her practice encompassed Minnesota, Liberia, West Africa, Alaska, and New Zealand. So all over. Her clinical practice has always been focused on rural and or underserved communities. She's worked in multi-ethnic inner city clinics in Minneapolis and St. Paul, with Alaska Native populations in remote villages north of the Arctic Circle, with Mandingo, Mono, and Geo people in war zones in Africa, leading to twice being evacuated, and in Madri communities in New Zealand. Her research interests include Agent Orange exposure and type 2 diabetes in Vietnam War veterans, with publications and international presentations under her belt. Dr. Bergum was raised here on the Iron Range and is a graduate of the Greenway High School in Coleraine. She attended Minnesota North College, Itasca, UMD, and the University of Minnesota. She and her husband now live in Isabella, where they have a culturally diverse family, including 3 children and 2 grandsons who love to visit us here up north. So I will hand it off to Dr. Bergum, and thank you. Just wanted to do a quick land acknowledgement. So we acknowledge that this region is home of the Anishinaabe peoples and in the 1854 treaty area, which includes ceded territory of the Bois Forte, Fond du Lac, and Grand Portage bands of Chippewa. And yeah, we continue to strengthen these relationships and learn more about these culture and more about the culture and the original peoples here.
Thank you. Thank you for the lovely introduction, and I'm so happy to see so many people here, many of my friends, and many of you will become my friends, I hope. When I was teaching, my theory of teaching is it has to be fun, there has to be chocolate, and you have to have something interesting to say. So you all find chocolate at your places, and I hope this is fun and interesting for you. So this is my picture taken out of an airplane window as I was flying into Ketchikan, Alaska. And I thought it was appropriate because we're talking about land and water treaty rights as a basis for Indian, Native American healthcare. And I caught myself, I'm trying to change my language so that I use Native American, American Indian, or Indigenous as terms, and I'm trying to erase the term Indian from my vocabulary as it is considered offensive to many people. So apologize if I slip up again. So flying into Ketchikan, Metlakatla Island is 20 miles by water from Ketchikan, and it is the only Alaskan reserve Native Alaskan reserve in the state of Alaska, and is an island. Yeah. I also want to thank the Tuesday group, my public policy team with the AAUW, to many Indigenous leaders who have met with us, talked with us, pointed us in the right direction over the 2.5 years that we've been working on this project. I especially want to thank Dr. Mary Owen. She is the director of the Center of American Indian and Minority Health at U of M Medical School in Duluth. She's been invaluable helping and teaching us on the healthcare and other treaty rights issues. Broken promises. The federal promise to provide Indian health services was received in good faith by our ancestral tribal leaders to lay the foundation for peaceful coexistence of our great nations. This is a statement from the Indian Health Board. By giving up tribal lands, the United States was able to prosper and build great wealth, leaving first Americans to try to build back a life within the new nation. The federal responsibility for health was prepaid by the tribes. The United States assumed this responsibility through a series of treaties with the tribes, exchanging compensation and benefits for tribal land and peace. The Snyder Act of 1921 legislatively affirmed this trust responsibility. So the federal government created the Indian Health Service, removing responsibility for tribal health care from the War Department, and tasked the agency with providing health services to American Indians and Alaska Natives. The federal government has never fully lived up to this responsibility. The terms codified in those treaties, including for provisions of quality and comprehensive health resources and services, have been reaffirmed by the United States Constitution, by Supreme Court decisions, by federal legislation and regulations, and even presidential executive orders. These federal promises, which exist in perpetuity, and that is the language in the treaties, collectively form the basis for what we now refer to as a federal trust responsibility. My biggest point in this talk is to dispel this myth. We've all heard it. My Native American friends hear it often, and it is a myth. Healthcare is a contractual right guaranteed by the treaties in return for millions of acres of land, and in exchange, Native Americans were guaranteed health care for themselves and their descendants. The point of this map is to show you that by 1899, and actually by 1867, 1899 is when the map was presented to Congress, there was no territory left in Minnesota that was not owned by the federal government, except for what we now call reservations. They were called reserved lands in the treaties. This is to show you the major treaties for Minnesota. There are over 300, about 350 treaties for the whole United States. There's, I believe, 18 on here that address the land transfer for Minnesota. The amount of land transferred is staggering, in the millions of acres of land and water. This map shows you the gray, which is all the land that was ceded, leaving tiny green spots for the Ojibwe reservations and very tiny red dots for the Dakota communities. In the treaty with the Chippewa of 1837, the services were federally funded medical care, education, housing, food, clothing, hunting, and fishing. And importantly, about the hunting and fishing and harvesting of wild rice, this is to be included in the territory ceded. And that's the phrase that has led to new laws regarding the area around Mille Lacs and now Upper Red Lake. There are some new initiatives to regain that land. In renewing the Indian Healthcare Improvement Act in 2010, Congress reaffirmed the duty of the government to American Indians and Alaska Natives. So this is ongoing. It's not something that happened 150, 200 years ago. This is something that has been constantly reaffirmed through our courts and our government that this is a federal obligation in return for land and water. A word about the cash payments. What was happening was the fur trade was no longer viable. And people who were coming into the state were looking at other sources of cash revenue, and they looked at timber. So the former people who had been negotiating the fur trade with our Native Americans now looked at timber, and what they wanted was land. So what often happened is they would buy land from the tribes for 2 cents an acre and immediately turn around and sell it for $10 an acre to the lumber barons. So, or to the state, for example, for the land the University of Minnesota is on. The other thing is the question often comes up, why was this deal negotiated? The tribal leaders were trying to guarantee health and welfare for their people. They could see that their battle against the new people was not going to be won. So they were trying to negotiate the best terms they could for their people. And again, the term in perpetuity is very, very important. They were looking ahead many generations. So always, we follow the money. The important thing to understand is that the funding for the IHS is discretionary. That means every year it has to be approved. It's not like Social Security or Medicare or Medicaid that have annual allotments within the budget. This is discretionary. And for example, if there's a government shutdown, which lasts for weeks, the tribe has not been, which in the last government shutdown led to having to furlough 25% of their employees at the clinics and hospitals because they couldn't make payday. So one of the big things is to try and change this so that it is on equal footing with other government health programs. Due at least in part to the failure of the federal government to adequately address the well-being of Native Americans over the last 2 centuries, Native Americans continue to rank near the bottom of all Americans in terms of health, education, and employment. Many Native Americans face unique challenges and harsh living conditions resulting from the United States having removed the tribes to locations without access to adequate resources, especially water, and basic infrastructure on which their tribal governments could foster living communities. Again, this is from the briefing presented to the U.S. Commission on Civil Rights in 2018. Native Americans are more likely to live in poverty, be unemployed, experience rape or abuse, and be killed by police than any other ethnic or racial group in the U.S. Native Americans have 1.6 times the infant mortality rate of non-Hispanic whites. So I think I've moved on to my next. Oh, funding disparities. So this is the current budget. If you look for every Medicare beneficiary, and I include myself in that category, $12,829 per year is what on average is what Medicare gives out. You can see 8,000 and some per veteran, 7,700 for Medicaid beneficiary. Indian Health Service patients, 3,000. Huge, huge disparity. Slide. Oh, and that slide was from the fiscal year 2020 Indian country budget request. All right. Chronic underfunding. Okay. Okay. Life expectancy. On average in the US, 5.5 years less than a non-native person. So that's all ethnic and cultural groups. However, this is not true state to state. For example, in South Dakota, the average life expectancy for a white male is 81 years. For a Native American male, it's 55 years. So huge, huge disparities. So these are some of the diseases that are higher in Native American populations than in the rest of the US. Not included on the slide is tuberculosis. In the 70s and 80s, there was a very, very successful tuberculosis program. And now it is creeping back. So we're seeing higher rates of tuberculosis, especially in places like Alaska, where access to healthcare and testing is really challenging. American Indians and Alaska Natives have the highest hepatitis C mortality rate nationwide. Overall, cancer rates for whites have declined from 1990 to 2009. That's where these numbers come from. However, cancer rates and cancer deaths have increased for American Indians and Alaska Natives. Moms and babies, especially at risk. Infant mortality rate is 1.6 times that of the rest of the population. Maternal death rate. So either during pregnancy, during delivery, or postpartum, 3 to 4 times is the death rate. And again, we're talking rates per 100,000 population, because the population of American Indian Native Alaskans is quite small compared to the rest of the US. So you can't just compare numbers. You have to compare population rates. There are higher risks of preterm labor, obstetrical hemorrhage, either during or after delivery, preeclampsia, gestational diabetes. Another infectious disease. This is the COVID death rate in Minnesota over the past 3 years, from March 1st to March 1st of 2023. The highest line that you see is American Indian. So this is an interesting thing, because the rate of infection for American Indian is about the same as the rest of the population. Rate of hospitalization goes up. Rate of ICU admission goes up. And rate of death goes up. I didn't include all of those graphs, but the bottom line is the death rate for American Indians is higher than the death rate for the people in New York City. And we all saw all over the news what was happening in New York City, yet the Navajo Nation had a much, much worse situation. So barriers to care. So on average, an Indian Health Service hospital is about 40 years old. On average, the hospitals that are not managed by the IHS or by the tribe are 10 years old. If you have a 40-year-old facility, it is 26% more expensive to maintain than a 10-year-old facility. The facilities for the Indian Health Service are also grossly undersized. They are only built to accommodate about 52% of the population that's actually seeing them. So you have crowded, even unsafe conditions among the staff, patients, and visitors. One of the things I've noticed is there's no privacy. You know, if it's a tiny waiting room and everybody is sitting there, everybody is knowing what's going on. What can we change? One of the big things is to change the mechanism of funding the Indian Health Service. We need a true needs-based budget with mandatory funding similar to Social Security and Medicare. That allows for inflation, price increases. When you have a yearly allocation, you cannot adjust for inflation. You do not get extra advances in case of a government shutdown or a pandemic. And your hands are tied because the allocation specifically says this money needs to be used for this, this, and this. So you can't shift monies around as your needs change. So trying to get the allocated monies into a needs-based budget with adequate funding is primary. Everything else falls from that. There are positive changes. Oh, I brought in the Indigenous healthcare track in the medical school. Dr. Owen and several other leaders in the Native American and medical school communities are developing a track on Indigenous healthcare that med students can take. And hopefully some of them will then continue to work in Indigenous healthcare. Some of the medical students are now requiring a 2-week track the first month of med school looking at Indigenous healthcare issues, but they don't have a whole curriculum yet, but it's a great start helping people understand what's at stake. I also want to mention that there's a program called TRAIL. It's TRAIL, and it's focusing on children and type 2 diabetes with the tribes. The curriculum is outstanding. The children form clubs, and there's everything from nutrition, fun, education and activities to lifestyle to healthcare. And if you're interested, you can look up TRAIL on the internet and find out a little bit more about that program. It's been very, very successful. Type 2 diabetes, the youngest Native American patient that I'm aware of is 4 years old. So in summary, my teaching points. Healthcare is guaranteed by treaties between sovereign nations. These treaties are also recognized by the United Nations as legally binding between sovereign nations. Healthcare has been woefully underfunded. The current allocation for 2023, I believe, is 14 billion. The need is 51 billion. The result of chronic underfunding is disease and deaths, and we see that. This picture I took when I was working up north of the Arctic Circle in Kotzebue. This is the Chukchi Sea, and in the background is the Brooks Range in Kotzebue. Thank you.
Hang up for that one. All right. This is on, okay. All right, so now we're gonna do some Q&A, so if you would like to ask a question, just raise your hand and I can bring them up to you.
Thanks, that was really interesting. Thank you very much. What department houses the Indian Health Service? Is it in the Department of Interior?
Yeah,
Okay.
it was in the Department of Interior. I know there have been some changes proposed to make it its own department. I don't know where that is in the process.
Well, so the Department of Interior is now headed by Secretary Deb Haaland, who is Native American. Has that resulted in any proposed changes to the funding for the Indian Health Service? Is her budget bigger in that category?
Yeah, the 2023 budget, even as underfunded as it is a big increase over what has been given historically. So we're starting to see changes on that. Details of that I'm not as well versed in as in the healthcare issues, but yeah, there's hope. And this $51 billion deficit, what they're trying to propose is that the $51 billion is paid out over 30 years. So if you look at it on a graph, now there would be a big influx of about $25 billion to try and catch up and get some new hospitals and clinics built, and especially get providers, nurses, doctors, techs, get those people through school and get them out to the clinics. So if you look at the graph, there's an initial peak and then it tapers. And so at the end of 30 years, if the budget allocations are appropriate, we're on track.
And then I have one follow-up question. Is there any legislation pending in Congress that would permanently fund the Indian Health Service?
It comes up every year. Yeah.
Somebody does
Yeah,
introduce a bill?
Yeah, and I'm hopeful that things will change.
Yeah.
Yeah, because the initiative is building, and as we get more Native American and Alaska Native people in government, then as we get more people who are concerned about these issues in government, then we have more likelihood of making a change, but it takes a long time.
Just to clarify, this is the crackly mic, so I'll probably turn it off once you ask your question.
Great, I've got two also. Is there any programs to try to get American Indians themselves trained to be doctors, nurses, stuff like that?
Yes, and there have been historically. In many communities, there are tribal funds. There also are funds from the IHS to provide for college education, medical school education, and residency for Native American students. The hope is they will come back to their community, and many do. But so that already does exist. Also, as through the government for non-Native people to train as nurses, optometrists, doctors, dentists, and so on. National Health Service Corps. And I know several of my former students who have taken advantage of that. And you get a dollar amount off the principal of your student loans for each year you go back, with maximum over 3 years, $70,000 total. And many people stay, which is the goal, but many do not. Many try and get their loans paid off and then they leave. So I would say there's moderate success, but I met many providers who were in the community for 20 years, 30 years. And the way they wound up there was it was a way to get their student loans paid off. The downside of that is there's a lot of physician and other provider turnover. Because after 3 years, you don't get any more money to pay off your student loans. So what happens is people will go up and work for 2 or 3 years and then leave. Having, so there's a constant turnover. You have a core of physicians who have been there for a long time, and then you have a core of people who come up just for a short time.
Oh, I'm sorry, my second one, with, Native Americans having, casinos and so forth. And getting a lot of money, which, they can do anything they want, well, they should. Has Congress used that as an excuse to underfund or not fulfill the promises of the treaties, because now they've got a bunch of money, they can do it themselves?
I don't know if Congress has used that as an excuse. I do know that most casinos are struggling and barely staying above water. Some are quite successful. But that's the rare exception in my understanding. That's another myth that they have all this casino money. And the reality is they don't.
This also is a two-part question, but I'm going to just give it as one. You didn't mention, I don't think, whether or not the Native Americans living anywhere, whether it's reservation or Minneapolis, they're mandated to have their health care at the Indian Health Service. If you would speak to that, or whether it's their choice. And then secondarily, I'm wondering, those of us who are left-wing politicians or interested in politics, always dream of a universal healthcare delivery system here in this country, so we can join the other industrial countries in the planet. If that were to come, would the Indian Health Service still be viable? If people had a universal government plan, would they still be giving care to the Native American population?
I'm going to address the second question first. The Indian Health Service only serves about 50% of the Native Americans in the US. So we still have 50% people uninsured and not getting tribal benefits. The other piece about the Indian Health Service money is that 70% of Native Americans live in urban areas, big cities, Portland, Minneapolis, and so on. But they only get 2% of the money. So that's another inequity. So we're left with many people living in a city that doesn't have an Indian Health Service clinic or hospital, and they don't have insurance. And we also have underfunding just on the global level. I think your first point about if they can go somewhere else, people can go somewhere else. Yes, let me speak to Alaska because I know that a little bit better. So in Alaska, in Anchorage, there are 2 hospitals. One hospital is the Native American Medical Center, and the other hospital is for non-Native people. So unless things have changed since I last worked up there, if it was a Native American patient I had in the ER, say up in Kotzebue, they were going to be flown to the Native American Health Center in Anchorage, which is an absolutely lovely facility. But if they were white or non-Native, Then they got flown to Providence. And that could trip me up because I had to bluntly ask people, you know, are you Native or not? Where do I send you? There's kind of an awkward question, but if I sent somebody to Providence and they were Native American, they wouldn't be admitted. They had to go to Native American Medical Center. And the people, Alaska Native people, in many cases preferred that because culturally, it's beautiful inside. 2% of all the money goes to artwork. So on every floor, there's beautiful artwork, beautiful cases with traditional crafts. In the center of the waiting room, there's a gathering center with a kind of a roof type building, a traditional gathering center. So if a person chooses not to go to one of the tribal run or federal government run health facilities, they are liable for the full cost. If they don't have insurance because they're unemployed or their company they work for doesn't offer insurance or whatever, then they're liable for the full cost, just like anybody else would be. So it's always a choice. Interestingly enough, last year, the federal government in their budget statement now recommends that the American Native population get health insurance because not all of their costs are going to be covered by the Indian Health Service, which is sort of an admission of gross neglect. But that statement came out in the public policy statement. Did I answer everything here? Okay. Yes, Angela.
On March 21st, I attended a hearing via Zoom. And it was at the state capitol. And it was HF 2876. This is a bill that supports financing the Indigenous health issues. So it's well received, bipartisan. So I'm very grateful that you're here today and that the state of Minnesota is taking action.
Thank you.
Hear me now, HF 27, sorry, what was it again? 2876. Another question here.
I just want to say thank you guys all for being here. This is really cool I've never been a part of the Tuesday group, and thank you, Linda, for everything, the presentation. And for everyone's questions, I do want to just throw out real quick in regards to the history that we've learned today about even just Minnesota land. We know that the onus of Native American, you know, all the funding that needs to go in for the healthcare specifically, right? We're talking about today, but even more so, it's not on Native Americans to make that change, right? They didn't force themselves on reservations. They didn't choose to not have money to give their kids healthy food, and now they have diabetes and other mental health conditions. And, you know, these things are not because of Native Americans, it's because of the white colonizers that came in. And so it's great that we have the trail and for things to support kids and get them out there. And it's wonderful that we've got bills coming up from the legislation, but it's people like us in this room right now getting together, talking about this stuff and being aware of it and really owning in on the people that are already in the Senate. Deb Haaland is one of them, but you know, even just because she's a Native American representative in politics, we know that she backed the Willow Project, which is tearing up Alaska right now, or about to be. So we really need to put the pressure on politicians and call those numbers and call those places that other people have mentioned. And again, I just want to say thanks for everything, and just, yeah, it's really complicated. It's a lot to do, and thank you. I appreciate it.
I just want to follow that up with an additional question. Are there advocacy groups that people could go to if they wanted to put pressure on politicians and or help in some sort of way?
I do not know the answer to that, but other than what we are doing in Ely with the AAUW and Empower, I will get that information to you. I'll talk with a couple people and get the information to you, and it can go out to Tuesday group.
Okay, perfect. Next question?
Yeah, I'm not gonna use the microphone. Real fast. Regarding, clinics and such that are part of the IHS, if I have it right, system, do they offer competitive jobs? One of the newly credentialed, osteopathic surgeon or passive gas or one of those specialties that first started getting money, are those places competitive to offer?
Yes. Actually, the salaries are higher, but the cost of living is higher too, for example, in Alaska, but in Minnesota, yes, the salaries are very competitive. I think you have to have a heart for the work because it's hard and it's frustrating to come bumping up against bureaucracy and lack of funding and so on. It also takes a long time to gain trust. You know, I was there maybe going up 3 years before I felt that people started to trust me. And sometimes people don't want to stay that long. I could always tell when people were starting to trust me when they would start talking to me about their mental health problems or bring their kid in, or you know, bring in a depressed family member. And that usually didn't happen until about the 3rd year. And then they knew I was coming back. So yes, the salaries are competitive. For example, a student who's finished their residency and is board certified and is going to fly up and under the National Healthcare Act. They get their moving costs paid, they get their housing, they get their salary, and they get a loan repayment. So yes, competitive. Sure, Ron.
Are there programs to develop more nurse practitioners, physicians assistants to serve rural tribal populations in Alaska?
Absolutely, and actually even in Minnesota, I know the movement is going that way, and dental technicians to be able to not only just do fluoride treatments, but maybe simple cavities and so on. I know Alaska has a pretty amazing dental assistant training program, and they're able to go into villages with a mobile unit. Also, the National Guard shows up several times a year with a full team and really takes care of the backlog. And they stay for a week and do a lot. Under the National Healthcare Program for students, all of those specialties are covered. So if somebody wanted to be a physician assistant, if somebody wanted to be an optometrist, if somebody wanted to be a lab tech, any of those are covered. There's a similar program for teachers.
One question in the back, and then we'll probably take one more after that, because we're getting close to time here, but
Hi, I was wondering if you'd comment on, is there on the medical education programs or funding, is anything going towards diet and nutrition? Because that's been undereducated in the medical schools, just in general, and so important for health.
You're absolutely right. Yes. I don't know about the funding for increasing diet and nutrition. I do know there has been a push, and it's driven by the medical students to include that in the curriculum. So hopeful, but I don't know the details of it. But the medical students are really pushing for some of these programs to be included.
I'll try to use this microphone quick, but thank you all. And thank you, Dr. Bergum. And we'll see you next week.